everyone, and welcome to tonight's session. We'll be getting started here in just a second. Just getting everybody's microphones turned up. My name is Angela Christ. I am the director of the Loeys-Dietz Syndrome Foundation and the director of marketing for the Marfan Foundation. And I also want to introduce you tonight to my colleague, Shaine, who will be posting in the chat box during tonight's session with resources and helping with any other things you might need throughout this. I'm sure she'll be wanting to hear where you're from and helping you direct any questions you might have into the Q&A. And with that, we'll get ourselves going here. Today marks the first day of sessions in our third and final week of the International E3 Summit, Educating, Empowering, and Enriching Our Community, brought to you by the Marfan Foundation and its divisions, the Loeys-Dietz Syndrome Foundation and the VEDS Movement, and our partners in Europe at Registrants. You all are making history. Every day we make even more history by our record attendance from all around the world. We thank you for making this such an incredible experience. This is by far the Marfan Foundation's largest event, with nearly 2,800 registrants from more than 72 countries. We hope you've had a wonderful opportunity or taken advantage of the wonderful opportunities to connect with people from all over the world in the app, and invite you to continue these connections after the summit. As you know, you are never really alone, even though sometimes it may feel like that within the rare conditions community. And we're so pleased that people have had such a wonderful opportunity to connect on all different topics. We are deeply grateful to our presenting sponsors, Brigham and Women's Hospital and American Communication Construction. Before we get started, I want to let you know that the International E3 Summit is a forum to provide an open discussion of issues related to genetic aortic and vascular conditions. Opinions stated in each of these talks are those of the speakers and not necessarily those of the Marfan Foundation or Registrants. If you hear differences of opinion from speakers and want further clarification, please contact our help center at marfan.org/E3ask. And we do ask for your patience for responses there, as the volume, you can imagine, is pretty high. But we do want to make sure everyone gets answers to the information that they are interested in or need to know, because that is exactly why we exist. So tonight, as we are going to talk about neonatal Marfan and LDS, your critical questions answered. We are so fortunate to have two doctors and a patient perspective with us tonight. We have Dr. Shaine Morris, Dr. Ron Lacro, and parent Alix Jennings, who are going to share both their expertise and their experience with us. And one more quick thing before I'm going to ask our speakers to say a quick introduction. As we are going through each of these sessions, whether you're viewing it live or later on, we would deeply appreciate your feedback on every single session. It takes less than a minute to review. If you can see, it says rate below the session, whether you're watching via the app or through a website browser. You click that button and it will ask you just a couple of questions. You can start right here as soon as you're done. And this is what helps us continue to provide information that is important to you, because that's our biggest priority, is to answer the questions that you need most. Following this presentation, there will be lots of time for your questions, so please do submit them into the Q&A. If you put them into the chat, we may not see them, so please do put them in the Q&A, and we will get to as many questions as we can. And with that, I would like to invite our presenters to say hello.
Hi.
Dr. Morris, would you like to go first?
Oh, hi. Sure. Hi, I'm Shaine Morris. I'm a pediatric cardiologist in Houston, Texas.
And I'm Ron Lacro, a cardiologist at Boston Children's Hospital.
And I'm Alix Jennings, and I have two daughters. My younger daughter, who's 13, was diagnosed at birth with neonatal Marfan syndrome.
And I've also been informed that Dr. Romano is on watching tonight from LIJ Hospital in Queens, part of the Northwell Health System. So hello to another pediatric cardiologist who is viewing here with us tonight. And to all of you who are viewing here with us tonight. This is an important and challenging topic, and we're so fortunate to have great minds to share with us tonight. So we're going to start with Dr. Lacro. Then we'll hear from Alix, and then we'll move on to Dr. Morris, and then we will cover questions. So Dr. Lacro, I'll turn it over to you.
Can everybody see my slides?
Yes.
All right. Hello, everyone. It's evening here in Boston, whatever time you're watching this. And we're all very pleased to spend time with you today to discuss Marfan and Loeys-Dietz syndromes presenting during infancy. I know that some of you have been dealing with a neonatal diagnosis for a long time, and for others, this might be a new diagnosis. So I'm going to start with a very brief introduction to Marfan and Loeys-Dietz syndromes. I'll describe some basic or normal cardiovascular anatomy and present the most common findings that affect the heart and blood vessels in babies and young children with connective tissue conditions. Then Dr. Morris will speak more specifically about neonatal Marfan syndrome and Loeys-Dietz syndrome presenting in infancy. And then we'll have lots of time for questions and answers. So Marfan syndrome was first described by a French pediatrician, Antoine Marfan, in 1896, so more than 100 years ago, when he wrote about a 5-year-old girl, Gabrielle, who had the skeletal features that we typically associate with Marfan syndrome. And you can see this picture of her with her long and thin arms and legs. And almost 20 years later, the ectopia lentis, or dislocation of the lens, was described along with those skeletal features. And in this photograph, you can see the edge of the lens here. So instead of the lens being centered right behind the pupil, the lens has been displaced off the center of the eye. And in the 1940s, there were case reports of aortic aneurysms and dissections or tears in the aorta in association with the lens dislocation and the skeletal features. And in these pictures by ultrasound and CT and MRI, you can see that the aortic root is enlarged. And the very beginning part of the aorta, the aortic root is very enlarged. In this middle picture, we see a picture of an aortic aneurysm at the time of surgery. In the aortic dissection, here you can see that the inner layer of the aorta has separated from the middle and outer layers of the aorta. And aortic dissection is the most serious complication associated with aortic aneurysms. So when this separation occurs, there can be chest pain, and if the tear progresses, this can be life-threatening or fatal. So here on this slide, we see the classic triad of Marfan syndrome: the lens dislocation, the skeletal features, and the enlargement of the aorta. No other syndrome has this unique combination of findings. And we now know that the syndrome is caused by changes or mutations in the FBN1 gene, which encodes the connective tissue protein fibrillin-1. Now, in contrast to Marfan syndrome, that we've known about for a longer time, Loeys-Dietz syndrome was described or characterized much more recently, first reported in 2005. And there's a lot of overlap between Marfan syndrome and Loeys-Dietz in terms of the clinical findings you might find in an affected person. But the first reports indicated a risk for a more aggressive blood vessel problem with Loeys-Dietz as compared to Marfan syndrome, and that blood vessels all over the body rather than just the aorta can be involved with Loeys-Dietz. There's also a finding of something called generalized arterial tortuosity, and I'll show you a picture in a minute. This is sort of where the blood vessels get longer and take a curly or curvy course through the body. And it's more common for children with Loeys-Dietz to have birth defects of the heart, things like holes in the heart or misshapen valves. These are much more common in Loeys-Dietz than they are for Marfan syndrome. Oop. And here are some pictures of the arterial and aortic tortuosity. So you can see in this picture on the left that the aortic root, the very beginning of the aorta, is enlarged. And instead of having a nice candy cane shape of the aorta, you can see that the aorta is elongated or longer in length, and then takes this sort of curvy shape through the body. In this middle picture, you can see, in addition to the aortic tortuosity, you can see that the blood vessels to the neck are very tortuous. And then finally, in this picture on the right, you can see that there are multiple hairpin turns of the vertebral arteries in the neck of a patient with Loeys-Dietz. And it turns out that arterial tortuosity can also be seen with Marfan syndrome, especially in the neonatal form. And the degree of tortuosity, the more tortuous the blood vessels, the higher the risk for dissection, aortic complications, and need for surgery. Children and adults with Loeys-Dietz are more likely than Marfan syndrome to have problems with cleft palate. Here's a bifid uvula, that little tissue that's hanging on the back of your throat is split. And again, people with Loeys-Dietz are more likely to have cranial synostosis, which is sort of a premature fusion of the skull bones, as well as abnormalities of the spine and the brain. And we now know that there are a group of different genes that can cause Loeys-Dietz syndrome. Let's just review some very basic cardiac anatomy in the normal heart. And in this cartoon, you can see that there are two sides of the heart. The right side of the heart pumps to the lungs. The left side of the heart in red pumps through the aorta to the body. And on each side of the heart, there's an atrium, the upper chamber, and a ventricle. And the ventricle is the more muscular or pumping chamber of the heart. And there are 4 valves in the heart, and the function of these valves is to keep the blood moving in the correct direction. From the right atrium, right ventricle to the lungs on the right side of the heart, and then from the left atrium, left ventricle, out the aorta to the body. And the most important heart problems that affect children with connective tissue conditions are usually on the left side of the heart, the mitral valve here and the aortic valve here. And this is the side of the heart that's under higher pressure, and the valves on this side of the heart are more likely to be involved. And here's a picture of an aortic aneurysm. So on the left, you can see a normal heart with a normal size aorta. And on this side on the right, you can see that the aortic root is enlarged. So to summarize, the most common cardiovascular findings we see with Marfan and Loeys-Dietz are progressive aortic enlargement. When the aorta is very large, we call it an aneurysm. There could be a tear or dissection of the aorta. And enlargement of the aorta can also cause leaking of that aortic valve. And regurgitation is just a medical term for a leaky valve, meaning that the blood, instead of going forward, is going backwards, causing the heart to enlarge and have to work harder. Other common cardiovascular findings, particularly in neonatal Marfan syndrome, is mitral and tricuspid valve prolapse. When these leaflets between the atrium and the ventricle tend to get flexible and the blood can go backwards across the valve, causing the chambers of the heart to enlarge and the work of the heart to increase. I've already shown you pictures of arterial tortuosity, which can be seen in both syndromes. And then these aneurysms and dissections of other parts of the, and other blood vessels other than the aorta, as well as congenital heart disease is more common in Loeys-Dietz syndrome. The last thing I want to talk about is Z-scores. So in adults and older teenagers with connective tissue conditions, we make our medical and surgical decisions based on the absolute measurements, either in centimeters or millimeters. Whereas in growing children, particularly in babies, there are limitations to the use of absolute dimensions because the aorta is going to be a different size depending on the size of the child. So what should the aortic size be for any given body size? And in order to answer that question, we use the Z-score. And for those of you who are familiar with standard deviations, the Z-score just tells you how many standard deviations away from average your measurement is, either above or below average. If you're not familiar with standard deviations, that's okay too. You can just think of the Z-score as a severity score. And in this graph here, you can see just the normal range for aortic roots for little babies on this side and adults, big adults here on the far right side, and everything in between. And what you see here are the actual measurements of the aortic root in one of my patients with Marfan syndrome from age 4 into his 20s. So if the Z-score is 0, that means that your measurement is average for that particular body size. If you're at the upper limit of normal at this top line, your Z-score is +2. And in this patient or this person with Marfan syndrome, you can see that all of the measurements are above the normal range, but not very far from normal. So all of his measurements have a Z-score of +2, between +2 and +3. If your Z-score were 5, for example, your measurement would be somewhere up here. So the bigger the Z-score, the bigger the aorta is compared to other children of the same size. And here on this graph, you can see the measurements from the same person with Marfan syndrome at age 4 all the way through into his late 20s. And you can see that the Z-score can go up and down over time. But over many years, the Z-score has really stayed between +2 and +3. So if the Z-score stays the same, that just means that the aorta is growing in proportion to the rest of the body. If the Z-score is going up, that means the aorta is growing faster than the rest of the body. So we would prefer that the Z-score either stays the same or goes down. I think that's what I have.
Okay, I'm going to share Alix's story now. Let me get you over here. Oops. Just make sure I've got this running. Okay.
Hi, my name is Alix Jennings. I live in New Jersey with my husband, Ezra, and my 2 daughters. My younger daughter, Cassie, who is 13 now, was diagnosed at birth with neonatal Marfan syndrome. So she's who I'm here to talk to you about. Cassie was able to be diagnosed at birth because during her newborn check, they heard a heart murmur, which meant that she had to go to the NICU. And when she was in the NICU, the cardiologist did an echo and saw that her aorta was already very significantly dilated. It was actually measured at 3 centimeters, which is around the size of an adult's aorta. She also had extremely long fingers, to the point where every nurse who saw her commented on them. And so those 2 things together, the long fingers and the size of her aorta, led to her diagnosis at 5 hours old with neonatal Marfan syndrome. And that diagnosis was confirmed a couple of weeks later through genetic testing. We were really lucky that Cassie was born when she was in 2007, because at that time, Hal Dietz at Johns Hopkins was already, had been working in his lab with a blood pressure medication called losartan that had been used for a long time to control high blood pressure, but he was newly using it to control the growth in the aorta. And we learned about losartan from our Cassie's cardiologist when she was born. So Cassie was able to start losartan when she was 4 months old, and that controlled the growth in her aorta until she was about 2.5, when it started to grow again, and she was switched to a drug called irbesartan, which is related to losartan but can be dosed higher. And the growth in her aorta has been well controlled since then. So I always say that the double-edged sword of Cassie's being diagnosed at birth is that it meant her symptoms were severe enough that they could be picked up at birth, but it also meant that she's gotten incredible care since day one. Even though she has not yet to have had surgery on her aorta, she did have another kind of heart surgery when she was 6 years old. Often kids who have neonatal Marfan, their first heart surgery is a mitral valve repair. And that was the case with Cassie. So we did that surgery at Johns Hopkins, and then 6 months after that, she had her first spinal surgery. She's had 2 more spinal surgeries since then and many appointments to lengthen spinal rods. But her final spinal fusion, which should be her very last spinal surgery, is actually next week. Another significant thing for Cassie was she had a G-tube placed at age 7, which ended up being a lifesaver for us. She was always thin and was actually diagnosed as failure to thrive, which is a really tough thing to hear as a parent, that your child is not thriving. But we resisted doing a G-tube for a long time, and then finally got to the point where we didn't really have a choice, and it ended up being the best decision we ever could have made for her. Our only regret was not doing it sooner, because after Cassie got a G-tube, we were able to really control her calories in a way that helped her gain weight, and she soon started gaining about 1 pound a week, and pretty quickly got back to a normal weight. And what was really incredible after getting back to a normal weight was that she had much more of a natural interest in food and a bigger appetite. So Cassie has been through a lot. She's had 8 surgeries and many, many, many doctor's appointments, and has had things she couldn't do, like play sports, but she also goes to our local public school. She'll be in 8th grade next year. She loves to sing and act, and she draws on her iPad. She taught herself to knit recently through YouTube and is making hats and scarves for family and friends. She loves to read. She loves to watch TV with her big sister and hang out with friends. One thing that's really, really helped us along the way is the Marfan Foundation staff. They've been an incredible source of support for us, as have the friends we've made in the Marfan and related conditions community. I always say that this is not an easy road, but there is a lot of support along the way that you can find through staff and friends that you'll make. So thanks very much for listening.
And now we'll pass it over to Dr. Morris. And then after that, we will take questions. All 3 of our speakers will take questions that you may have to finish us up tonight.
Thank you guys. And thank you, Alix, so much for that. That was really lovely to hear and reminiscent of so many of our patient stories. And I think your stories are the most important because this is such a rare condition. And I feel like every time we hear a new story, we learn more. I'm just going to talk a little bit about the specifics of neonatal or infantile or early onset or severe Marfan syndrome. You'll find it called all 4 things. This is a patient of mine who's just a wonderful little guy and agreed to have his photos in this. But just if you're ever kind of looking it up, like it says, it has all these different definitions or names: infantile, severe, or early onset. I know Dr. Dietz is predisposed to start calling it early onset. He likes that definition currently a little bit better, meaning that some of the skeletal and eye features come on earlier. The features we commonly see, we've heard a little bit described. So pretty prominent facial features: downward slanting and deep set eyes, an aged looking face, and that's because of lack of fat stores in the face, so it makes the face look older, unlike most young children. Crumpled ears are very common, loose skin, early onset of skeletal features. So most children with Marfan syndrome you won't see scoliosis till around the pubertal time, a lot of the leg anomalies, and you'll see these come on really early: pectus in children with neonatal Marfan syndrome. It's pectus, scoliosis, contractures, increased joint laxity, and long fingers and toes, of course, which we can even see. I do fetal cardiology, as does Dr. Lacro, and patients with neonatal Marfan syndrome, we actually see the long fingers in utero. So they can also have early lens dislocation or very severe myopia, that's nearsightedness, emphysema, which is lung disease, and a kind of lung disease. Poor eating and weight gain is really common. I think all of my kids right now, I've seen 4 that are under 10 and they all have G-tubes. That's very, very common. I think it's just a lack of wanting to eat, is difficulty gaining weight. But a main concern that we worry about that can be life-limiting is the cardiac features. So the main, as Alix alluded to, the main feature we see is mitral valve prolapse. And like Dr. Lacro showed, this is when the valve doesn't close properly, and that causes the valve to leak or have regurgitation, or we also call it insufficiency in infancy. And this can really make the heart work harder and can result in what we call heart failure, and that the heart has to keep up so much effort to keep up with the heart beating that over time the heart can get very dilated and function poorly. We can also see severe aortic root dilation at an early age, although again, as Alix mentioned, the mitral valve disease usually is even more severe than the aortic disease. We can also see tricuspid valve prolapse. That's the similar valve to the mitral valve, but on the right side of the heart. That can also prolapse and have regurgitation. And we can see something called cardiomyopathy. And this is where the muscle of the heart doesn't seem to function properly. We will see that the heart can get bigger, even if the valves are not terribly leaky, even if the valves are corrected, and that the squeeze of the heart cannot be as typical as we would typically expect. So now the presentation can vary really widely. Not everyone has the same features. And so this is what has led to a lot of the different people calling these different diseases. You know, it used to be, well, if you got diagnosed early, you had neonatal Marfan syndrome. But now with easy genetic testing and molecular testing, lots of kids with sort of more typical Marfan syndrome get diagnosed early, but that doesn't give them this condition. And not everyone has all these diseases, all these features, and so that's what makes it hard. Now, mitral valve disease is one of the most common features we see in neonates, and certainly when I see a young child with severe mitral disease, I wonder if we're in this category and do further workup. Now, being diagnosed in infancy, like I mentioned, is not equivalent to neonatal Marfan syndrome. As like I mentioned before, lots of kids are diagnosed at an early age now because genetic testing is so easy and because the parents have been diagnosed. So now what about early onset Loeys-Dietz syndrome? I'm not going to talk a ton about this, but basically this is much more of a continuum in Loeys-Dietz rather than a separate diagnosis. In Marfan syndrome, we really do feel, although there is some overlap, there's a really severe form and sort of a more mild, varied form. But in Loeys-Dietz, it seems to be much more of a continuum, but certainly some children present much more severe at a younger age. They tend to have much more severe tortuosity. I actually take care of a young man that we realized he had Loeys-Dietz because when they did his echo, his aorta was going horizontal rather than vertical, and it actually took a hairpin curve his aorta in the chest, and that's how we figured out that he had something going on and had Loeys-Dietz. They also have much more severe vessel dilation, and this can be both the aorta and the pulmonary artery, loose skin, just like we see in neonatal Marfan syndrome, and increased joint hypermobility and contractures are very common in Loeys-Dietz. Now, going back to Marfan syndrome, what about the genetics? So the FBN1 variant is almost always de novo. That means it was not inherited from either parent. And it doesn't mean that patients with neonatal Marfan syndrome can't have kids, but historically, I think they've probably just been too sick. And so almost all of these are brand new mutations. Now, there is a case of germline mosaicism reported. And what that is that's when only some of a parent's cells have the gene for Marfan syndrome. So not all their cells have it, so they don't have it, but the sperm or the eggs might have it. And so there's a case of a family where the male had some of his sperm carried the gene for Marfan syndrome, and he had 3 children with neonatal Marfan syndrome, even though he didn't have it himself. Now, the mutations in FBN1 or the variants are usually between exon 24 and 32 in neonatal Marfan syndrome, and the majority are between exons 25 and 26. Now, how do we take care of kids with neonatal Marfan syndrome? It takes a team, as anyone can tell you. So certainly genetics to help with the diagnosis, cardiology and cardiac surgery. I think we become sort of the PCPs, pulmonary to help deal with the possible emphysema, the pectus impairment on lungs, sometimes asthma is a component, especially in the Loeys-Dietz patients, ophthalmology to help with lens dislocation and myopia, orthopedics to help with the scoliosis and possibly other orthopedic issues like contractures, and general surgery, especially to help with hernia repairs, which are also quite common in this population. So how do we treat if the valve leakage, the insufficiency or regurgitation, which can lead to heart failure and historically has been the main cause of death in children with us? So we have multiple things we can do. We can give medicines in the category of beta blockers. These are the same medicines we also give for aortic dilation. These usually end in a lull, called carvedilol or metoprolol. These slow down the adrenaline system in the body, lower the heart rate. We can give ACE inhibitors. These end in pril. And these sort of help the hormonal system around the kidneys lower the blood pressure. Similar to the ACE inhibitors is another class of meds, the angiotensin receptor blockers, or ARBs. These are the ones that Alix and Dr. Lacro mentioned, including losartan and irbesartan. And these have been really helpful in Marfan syndrome because in addition to helping with aortic growth, there's some question about whether they help with remodeling. And so I think a large number of our patients with neonatal Marfan syndrome are on one of these medications. We can give diuretics, and common ones are furosemide, which is also called Lasix, or chlorothiazide, which is also called Diaril. And these help you excrete more fluid. So when you have heart failure, children tend to build up fluid in their lungs and their heart, and these help them get rid through their urine of fluid. Digoxin, which is a heart medicine, which can sometimes make people feel better who have heart failure, can possibly help the squeeze of the heart. And ultimately surgery, and like Alix mentioned and Dr. Lacro mentioned, the surgery for mitral valve disease often in this population is a mitral valve repair or possibly replacement, or a repair followed by a replacement to stop the insufficiency or the regurgitation. Now, if the mitral valve is replaced, that's usually with a mechanical valve, And because that's a mechanical valve, we usually need to then start a blood thinner, and the most common is warfarin, which is also called Coumadin. Now, some patients, the surgical treatment just doesn't work or isn't possible, and some children with neonatal or infantile Marfan syndrome have undergone heart transplant, which has been successful in most of the cases I'm aware of. So what about aortic, the aortic enlargement part? So this doesn't typically cause symptoms, but we worry about dissections. We do give beta blockers, again, to sort of to lower the stress on the aorta. We also give those ARBs I mentioned, losartan and irbesartan, because those medicines also appear to slow the growth of the aorta, and probably in combination with beta blockers are the best in the more severe cases. We do frequent imaging to look for any rapid dilation that we might have to treat, and ultimately surgery. The most common surgery is aortic root replacement. This is a picture of a dilated aortic root and of an aortic root replacement, where that aneurysmal area is cut out and replaced with a graft, which is the most common. Now, we still worry about dissections, and one of my patients had a dissection at age 10, so we worry about aortic dissections, like Dr. Lacro mentioned, in this age group too. So what about respiratory issues? Just to show you, this is a diagram of a pneumothorax, a collapsed lung, and this is an actual picture. You can see that it's black in the background. This is one of the complications. Some of the other complications can be floppy airways, which can cause obstruction, so the air can't get in and out properly. Muscle weakness, so the diaphragm is the muscle that helps you breathe, and sometimes that can be weak and can decrease the effort, or it can impair the breathing effort. The diaphragm can actually have defects, like a hernia through the diaphragm, that can cause it to dysfunction, or it can dysfunction without a hernia. There's chest wall deformities, a pectus, where the chest wall caves in or caves out, or scoliosis, and because the back is curved, the lungs can't function perfectly. Emphysema, which is destruction or widening of air spaces in the lungs, and that can lead to atelectasis or pneumothorax, which is this collapse where we get a collapsed airway, or an air can leak all around the lung, and the lung collapses. Also, a small number of patients can experience pulmonary hypertension, and this is increased blood pressure in the lungs, and that can put excess stress on the heart. Now, what about outcomes? So unfortunately, this is such a rare subset of Marfan syndrome that not much is known. Almost everything we know is from case reports and, of course, our experience. And most papers out there are 1 to 3 patients, and the outcomes are really variable. The largest paper ever published is from 60 kids. This was published almost a decade ago, and they were diagnosed under age 1. So not all of them were what we would typically call neonatal Marfan syndrome. This was unfortunately a pretty depressing paper. About 60% had died by age 1, and 66% of the kids had died by age 5. And most often this was due to heart failure, and sort of suggested a really grim prognosis. However, I'd say I think things are changing, and we're actually working to understand what the contemporary era looks like. Because even in this 2011 paper, they were going back 20 years. So a lot of them were reporting their outcomes from the 90s. So these are some of the case reports that are out now. And these are all cases, now they're small, they're 1 to 3 patients, of patients that underwent early mitral valve surgery and are thriving. And this last paper was 3 patients, a 9-year-old, a 12-year-old, and I believe a 7-year-old, that all had successful surgery and were doing well. And I know in our clinic, we have had 1 patient pass away recently, but we have 4 patients under 10 right now, and I think we have 2 teenagers that they definitely go through a lot. There's definitely, they have a lot of providers, but I think that outcomes are gonna look better now with a really coordinated care. Now, if you haven't heard about this, we are doing a study that we'd love anyone interested to participate in. This is actually funded by the Marfan Foundation, and it's through University of Texas and Dr. Milowicz. But I'm heavily involved in this project. And we're basically enrolling anyone who has a child with neonatal Marfan syndrome, or if the child is passed, they're still eligible. And we would love to enroll them to find out more about the current natural history. Now, if you're willing to enroll now, we're actually doing food diaries and looking to see if there's a certain hormone that actually causes appetite suppression. But in parallel with this study, we're also looking at everything that's happened in the past, just so we can better describe what kids in the current era look like with neonatal Marfan syndrome. So it was wonderful talking with you guys. I'll take my screen off, and I look forward to hearing your questions and hearing your stories. Thanks.
Thanks to all 3 of you. Helene did drop the link to several resources that may be of interest to folks tonight, or who are also interested in this presentation, including the link to the current study that Dr. Morris mentioned. We always refer anyone who is experiencing neonatal or early onset, however you want to call it, to that study, because it's just one of the main ways we will be able to find our way to a better future for folks who experience this. So, given all of that, thank you, all three of you, by the way, for really excellent information. There are a few questions that I will share with you, and if you are on now and would like to submit an additional question or have any others as they come up for the remainder of our time, please drop them under the Q&A in the Whova app or online, and we will get to them here this evening. First question is directed at Dr. Lacro specifically, but I suppose it could be to either of you. Any new data on outcomes for neonatal kiddos? Any promising drugs or research?
Yeah, I'm not sure I have anything special to add other than what's already been presented. I think it's, I wanted to reinforce Dr. Morris's call for gathering more information, because I think, case reports of small numbers of people can only give us a part of the picture, right? It's like the big elephant, and we need a better picture of what kids are like, especially now. It's always been a challenge even defining Marfan syndrome or neonatal Marfan syndrome, because some people defined it by how long they lived, and clearly that's not how we should define a syndrome. And so I think, surgery certainly is a big part of it, whether we're talking about eye or orthopedic or hernia and certainly cardiac. Medical therapy, as we've talked about, for the heart disease. I think part of one of the biggest challenges that I would love to learn more about in terms of treatment is the lung problems, because I think particularly when infants have emphysema, and I've had a number of patients have emphysema, there's, that tends to be progressive and not reversible and not treatable. So we obviously do the best we can, but I think that's sort of the big link. And I find that kids that have significant emphysema do very differently from those that don't. So I don't know if Shaine wants to add anything more to that.
No, I mean, I think that's it. I think there's some hope for some of the ARBs, but we haven't done any studies or long-term studies to see if there's effects beyond just the aortic root growth, whether for the myocardial remodeling or for the lungs. There's some animal studies that suggest it might be helpful, but to date, the animal studies haven't translated that well to human studies. So, there's some cautious optimism.
So the next question I'm going to ask, this might actually have, all three of you may have some good input on this one, of course, from the doctor perspective, and then also Alix as a parent. So this one says, I'm currently in the hospital with my 1-year-old neonatal son who is having a surgical repair on his mitral and tricuspid valves and a severely dilated aortic root. What should I be expecting from our doctors and going forward from here and caring for him both before the surgery and after? And I want to toss out that there is a resource that we dropped into the chat about preparing your child for surgery, specifically or aortic surgery, that might have some helpful pieces of information in it, but that's more generally speaking. So to the three of you, sort of looking at expectations going forward.
I mean, I think we can all talk. I think that's hard. I think it's really common for kids with neonatal Marfan syndrome after surgery to have a pretty long recovery. It's not uncommon for the ventricles to get a little stunned and to have a little dysfunction, and also for the feeding to lose ground feeding if you don't already have a G-tube. And so I think those are two things, is just to have a lot of patience and ask for a lot of family support. As for asking about your doctors, I mean, hopefully just making sure they're knowledgeable and patient and understanding of the expected complications. But I mean, it seems that mitral valve surgery has been really a game changer in these patients. So that often is the right route, but it can take a while to recover.
Right. So what I would add is, obviously we don't have the details, specific details of this particular family and child, but, sometimes in older patients, when we, some more classical Marfan syndrome patient where you have a mitral valve that needs repair, sometimes we say, oh, we're going to be in there, let's just do the aorta at the same time, even though it may not, may not be quite at 5 centimeters. I would be very, careful about, whether the aorta really needs to be done. In many neonatal Marfan syndrome patients, if the primary problem is the mitral and tricuspid valves, which is more common actually at younger ages, I would not take on the aorta unless the aorta was really rapidly growing or really had changed. There are definitely instances where, the aorta is expanding, the mitral valve is not good, and we have to do everything. But the addition of the aorta to a mitral valve surgery is not trivial. And if it doesn't have to be done, I would probably just try to do the mitral and tricuspid valves first. I think it's a little bit different from, the approach with classical, and maybe less when the patient might not be as sick, to just go ahead and do it all. We're there, let's just do it all, right? That's sort of a surgical approach. We're in there, let's just do it all. But for a baby with neonatal Marfan syndrome, adding the aorta, if it's really not necessary, might be the difference actually in the recovery.
I was actually going to say the same thing. I'm so glad you did. And because it's just specifically, it makes the bypass time longer. So you have a longer time where your heart's not getting blood, where the baby's cold, and then can have impairment. So 100% agree.
We actually got that advice before Cassie's mitral valve repair because her aorta was already significantly dilated. There was a thought by one surgeon that he would just do it all. And we got the advice not to do her aorta at the same time. The way it was described to us is that her heart was just so tired from working as hard as it had been for so long that if we just did the mitral valve repair, which was in it by itself, a long surgery, 5 or 6 hours or something, I don't totally remember, but then with the mitral valve repaired, it would give the heart chance to recover a little bit so it could then get through an aortic surgery better. And I also just wanted to say something that Dr. Morris said about the G-tube, that if your baby doesn't have a G-tube already, I would at least ask about it, just to be sort of as sturdy and as, full of nutrition as possible prior to the surgery, would be the best case scenario then.
Alix, anything else you would share sort of parent to parent, that you would want to add?
I'm not going to pretend. My daughter's first surgery was at 6. That was the mitral valve repair. And even 6 is different than 1. 1 is really hard. That's a little baby, and it's a lot to go through. A sort of weird advantage, I guess, is that, a 1-year-old doesn't know what's going on exactly. So they don't have to be anxious about it or anything like that. But I don't know. All the doctors, and I actually was sort of kicking myself watching the video of me talking because I mentioned the staff at the Marfan Foundation and friends we've made, and somehow didn't talk about all of the amazing, amazing doctors and other medical professionals who are involved with the Marfan Foundation. So, we've been so lucky to have such incredibly caring doctors who've really taken such good care of Cassie and of us. I know pediatricians always sort of joke that parents are as much of their patients as the kids are. So I don't know. I think, you sort of have a gut feeling about a doctor or a surgeon and to go with your gut. So I don't know if that's helpful, but I just wanted to acknowledge that, that's, it's a very little baby, so it's really, really hard.
Thanks for your answer. I know that these are such nuanced situations. It's hard to speak broadly, but I know it's just knowing that there are other parents who have been through this is powerful enough. And I think Maria was the name of the person who asked that question. If you're still on and listening, please do reach out to us. Please do reach out to others who have been there and done that. You don't have to go through it alone, and neither does your child. And we're here to support you in any way we can.
And Maria, and it's Helene, you don't see me. Maria, I'm sending you a message as we speak. So.
She's Helene, our magician behind the scenes there. I'm going to stay on this topic sort of for a second here. Is there a limit on the number of open heart surgeries a neonatal kid can have?
You want to start, Ron?
No. I don't think there's a maximum number or a limit of operations. Obviously, we want the operations to last as long as possible and minimize the total number. I think the age at your first surgery is an indicator or can be an indicator of severity of disease. So, if obviously medical management is important too, but I think the sicker kids are going to need their operations, frequently in the first year of life. I think, at least the surgeons at our place have kind of learned some techniques. These are very difficult valves to repair. These are not valves for new surgeons without experience. I think, and the valve can look perfect at the end of the operation, and days to, months later, the valve can fail again. So I think that, having a really experienced mitral valve surgeon is really important in minimizing the number of operations.
Still on mute there. One more on this part of the topic. Is there a set measurement or range of the aorta that is a threshold for aortic surgery? I know you kind of touched on this, but maybe to...
I think it's really hard, and I'm curious to hear Ron's perspective on this. There's no, in older kids, we use 5 centimeters generally, unless there's extenuating circumstances like pregnancy or another surgery or rapid rate of growth. I think in kids, it's really hard. We don't have any published firm cutoffs because we don't have outcome studies. I tend to, in really young kids, 2 of my patients got mitral valve surgery under 2 and then an aortic surgery by 4. I think if they're under 5 or 6, I generally feel like if you're getting in the high 3s to low 4s is when I present for surgery, but that's just based on experience and reading, and we don't have fabulous data. I don't know what your cutoffs are, Ron, for young kids.
Yeah, really high Z-scores are pretty rare, so once we get above 7, 8, we definitely see them up in 10 and more, but, so when you get your Z-score up to 10, you're sort of self-identifying as a higher risk candidate. But having said that, I have patients who have been Z-score 10 for many years, and their aorta is, not progressing. It's just kind of growing with them. So like Dr. Morris said, there's not as clear a cutoff in kids as there is for adults. I think part of that is, kids are smaller, so their aortas are smaller, and sometimes I think the actual size, the dimension, has something to do with it. I think it's rare to be rapidly progressive. I had one neonate who basically increased by 1 millimeter every week for 12 straight weeks, and Z-score went rapidly from 7 to over 15. So there sometimes are clues, development of a leaking of the valve, sort of increasing Z-score that's consistent and persistent. You know, those are sort of the things, but it's definitely not as black and white as the adults or older teenagers. And then for the mitral valve, you know, I think we use things like size of the heart. We can use MRI to sort of quantify how much blood is going backwards, and that those can be helpful. But oftentimes just the clinical presentation, you know, if somebody is really dependent on a ventilator or not gaining weight or losing weight even. And one of the dangers of real severe leaking of the mitral valve is that as the heart gets bigger, that means the space for the lungs is smaller. So the heart will enlarge to a great degree, and for every degree of enlargement of the heart, that means the lungs are smaller. And that can sometimes be enough to push us to try a surgery.
Thank you both for those answers. Moving to a little bit different angle. In your experience, is a spinal growing rod inevitable for early onset kids? And if so, should we intervene sooner on scoliosis?
I don't know, Ron, can you comment? I mean, I'm trying to think if any of my patients have had a spinal growing rod. Most of them have had scoliosis surgery at some point, but I don't think it's inevitable because I have teenagers that don't have it. But what do you think, Ron?
Yeah, it's really variable. I mean, I think that sometimes the scoliosis is quite severe, and I've had a few patients, unfortunately, who's just could not hold a growing rod. The rod kept breaking. Just because of the tension from the curve. You know, it's one of those tough questions sometimes, when to do something or when not to do something. And a lot of times it's a balance of not just the spine, but what else is going on. I mean, if the spine were the only problem, you know, clearly progressive scoliosis can lead to pulmonary problems in the long term and cardiac dysfunction and all of that. But it's really, I think, one of the challenges of management of neonatal Marfan syndrome or severe Loeys-Dietz is trying to balance multiple different issues. And frankly, sometimes the answer is not clear. You know, I think that people with patients or children with neonatal Marfan syndrome are more likely to require more aggressive scoliosis surgery, sort of like a real fusion rather than growing rods, just because they just won't stay straight enough with those growing rods and they'll break.
Thank you. That is, it's just also complicated and interconnected. I appreciate your thoughtful comment on that. Here's one slightly different again. Our 3-year-old has a very extensive dural ectasia. It's hard to say if/when, how much it could be contributing to his mobility/toileting issues. Any advice on what we could or should be doing?
That was for you, Dr. Morris.
I mean, all I can say is to work closely with the neurosurgical team. I mean, you know, where the degree of dural ectasia certainly can cause a lot of my kids do have dural ectasia, and it mostly contributes to pain, not dysfunction. But it's certainly within the realm of possibility that it's contributing to abnormal toileting. But I think someone has to look exactly at the anatomy and talk with the neurosurgeons. I know our pediatric neurosurgeons are really reluctant to intervene on dural ectasia in young kids because the outcomes, whether it improves things, are limited. So they really try to get through symptom relief if possible. But I think it's probably so individualized, it's hard to say.
Yeah, the only thing I would add is that dural ectasia is really hard because, you know, many people have dural ectasia and have no identifiable symptoms associated with it. And so when you have a symptom and an imaging finding, you know, it's not always clear that they're actually related. So just try to get the best experienced person with dural ectasia, but it can be very hard to sort of clarify you know, how important dural is in any particular person.
Another one has popped. Oh, here's a couple more. How long do bioprosthetic valves usually last in neonatal Marfan infants?
Oh, that's a good one. I think all of our patients have had primary repairs followed by a mechanical valve or just kept their repair. So I don't think I can comment on neonatal Marfan syndrome. Generally, bioprosthetic valves don't last as long as prosthetic valves. You know, we sometimes say 5 to 10 years, but if you're putting in a young infant, I think it's much harder to comment.
Yeah, I would agree. I mean, I do have some experience with bioprosthetic valves. I mean, they, especially the younger you are, it seems like the shorter they last. The leaflets can get calcified, and you know, we sometimes choose bioprosthetic valves to avoid Coumadin, but I think you know, the results are usually better with prosthetic valves if the patient is enough. So yeah, you know, sometimes you just have to do what you can do. And so you might get a fair amount of time with bioprosthetic valve, but I think in a very small infant, it's gonna fail at some point. I think in the future, we may be able to, again, dependent on size of patients, but be able to put a valve inside a valve in the cath lab. So it does leave the possibility, whereas with a prosthetic valve, you're not able to sort of put another valve in it in the cath lab. But with a bioprosthetic valve, there is at least in theory, and we've done it in not Marfan patients, but other patients where you can actually, through a catheter, put a valve inside the bioprosthetic valve. So that's a possibility for the future.
Here's a question about weight gain. Any advice on supplements or strategies for weight gain prior to the path of a G-tube, particularly in the lead up to surgery? She says 6-year-old.
You want to start, Ron?
Or Alix, did you have a thought on that? I know you started.
So, I mean, I actually wrote a series of blog posts for the Marfan Foundation website on weight gain, and what helped my daughter Cassie gain weight. She had a G-tube when we did it, so it was a lot easier because I could control, you know, how much she was eating. There's nothing more frustrating than your child needing to gain weight because you can't force them to eat. But basically it involved counting calories, which is really, really hard to do, and actually a lot easier. That's a lot easier with a G-tube as well. But it was the process that worked for us basically was we would weigh Cassie every morning, and then count the calories we gave her over a 24-hour period, and then weigh her the next day. And if she weighed the same amount or had gained weight, we gave her the same number of calories the next 24 hours. And if she lost weight, or if she stayed at the same weight for more than like 2 days, we added, for her at the time, it was 150 calories. That's how much we added. And through that method, she gained a pound a week until she got to a normal weight. And she's currently still 6 years later at a normal weight. She's at the low end of normal, but it's, so if you're interested, if you go to marfan.org and you search for, I guess it would just be weight gain. My blog post should come up that described what we did. It's an incredibly frustrating process. It is so hard. I'm not someone who's ever had trouble gaining weight. And I just, it's incredibly frustrating, but it is so worth it. And it's hard with a surgery deadline. I don't know how far out you're talking about with surgery, but anyway, and people talk about shakes, and I mean, if you go on, a Marfan Facebook group, I mean, there are a gazillion questions about gaining weight, and people talk about all the shakes you can drink and stuff like that. We tried that first, usually with Pediasure, and she just got to the point where she would honestly throw up just smelling it because she just couldn't stand it anymore. So it's really, really, really tough. And that was what led us to the G-tube. But it's really hard to add calories in a way that's appealing for a kid who maybe doesn't want to eat.
I just wanted to highlight, I think, oh, sorry.
No, go ahead.
What you point out, the source of anxiety and stress and frustration in feeding is consistent among so many of my patients. And I think it needs to be recognized, and I'm glad you're talking about it. I mean, we have families trying to do everything they can for their child, and it is just a source of having this feeling. And this is what they tell me, a failure, because you can't feed your child. And that feels like it's the most basic of things, but they really just have a hard time. And it's repeated every day because it has to happen, you know? And so it's really, really challenging. And I think working with your team, and if it's a G-tube, if it's a different formula, but it's important, and you have to try really hard not to overcome that anxiety, because it is just so hard. And I'm so happy when families, just my neonatal families, my regular patients with Marfan syndrome don't need it, but when they have gotten a G-tube, it's so tremendously helpful and just alleviates this huge weight.
Sorry, I was just dropping those blog posts into the chat. I've got the first two in there. I'll get the third one here in just a second. One final question as we wrap up, and just a note, if we are wrapping up here, and if we did not get to your question, or you have other questions that come up later, whether you're viewing this later or just really any time during the summit, you can submit that to marfan.org/E3Ask. And really anytime you can submit questions to our on-staff nurse and social worker, who they also work in conjunction with our professional advisory board and other deeply passionate and experienced physicians and surgeons who help us answer questions of all types. Again, that's why we exist. Please do use us as a resource. We want you to have the information you want and need. So our last question here, what recommendations would you have for parents outside of the US, this one specifically mentions Canada, to ensure their kids with neonatal Marfan syndrome get the best care possible?
I think stay in Canada. Canada has a tremendous medical system. Seriously. I think if you're connected to a major medical center with experience of Marfan syndrome, and many of us collaborate or communicate with each other when we have challenging patients, and so even as providers at major centers, we're not working in a vacuum. It's not infrequent that Shaine and I will email each other and say, have you seen this? Have you tried that? And so I think just sort of staying connected with the Marfan community as a whole, and encourage your local providers to do that as well. I wanted to sort of deviate from the question a little bit, and just, I really loved when Alix was talking about how Cassie sings and acts and watches TV, enjoys her sister, and learn to knit. I really hope that families dealing with this diagnosis can do everything possible to have their child have as normal a life as possible and not be defined solely by this diagnosis. And some of my youngest patients have been the brightest, bravest, most courageous, clever, sometimes mischievous, and wise children. Even some that have unfortunately not lived for very long. So I think I learn from every one of these kids, and I hope that we can get better at improving survival. And we spend a lot of time talking about medical complications, but I love those stories about just normal life that Cassie has, as much as she can. So thanks for sharing that.
Sure.
Dr. Morris, did you have anything you wanted to add to that question? Or
the only thing I was going to say is there is a Canadian Marfan Foundation. Well, now it's called GATA, the Genetic Aortic Disease Association, that has great Canadian resources. And I know that 4 cities host major aortic conferences, and there are centers that have an aortic an aortic focus. It's Halifax, Montreal, Toronto, and Nova Scotia, I believe somewhere in Nova Scotia. And so I know that there are aortic centers there, and I think they all have pediatric affiliates. So I know that those are major centers in Canada, but the data might be helpful too for finding specific providers.
Awesome.
Can I just add quickly to something Ron said? Ron, thank you for saying all that about Cassie. I wanted Helene to know you're welcome to put my email address in the chat and if anyone wants to get in touch. I'm happy to talk anytime about, anything you think I can help with as a parent. If you're on Facebook, definitely join the Marfan groups. And we actually have one specifically for parents of kids with a neonatal diagnosis. So if you friend me on Facebook and I'm under Alix, ALIX, McLean Jennings, I can hook you up with that. There's always a ton of support there. And support from other, I was going to say parents, but for me, it's really moms. Support from other moms is really helped so much. Cassie, when I was talking in the video about the spinal surgery Cassie was about to have, she had it almost 7 weeks ago. And I can't tell you the number of texts I got and calls I got in the hospital from other Marf moms, as we call each other. There's just unending support out there in case you are new to all of this. So please reach out and, we're all here for you.
Thank you for sharing that, Alix, and both Dr. Lacro and Dr. Morris. This is, like we've said, it is a challenging topic, and one we're so grateful to have you guys all sharing on for this session. Just some final thoughts as we're wrapping up. Again, if you have questions that come up at any time, you can submit them to marfan.org/E3ask. As you wrap up, we would love for you to complete the session survey. It helps us so much in planning future educational opportunities. There are additional resources and people who can be a support to you in the virtual exhibitor hall. Much like Alix just said, find your way into the community, whether it is, there's a lot going on in the Whova app or through the URL that you can connect with parents, other folks who have experienced these conditions, or really people are connecting on all kinds of different topics, and we invite you to join in on that. And if you're sharing online through your social media accounts, another great way to connect with others is by using the hashtag E3Summit20. And then finally, if you are interested in seeing more educational and community programs like this and this whole summit, we really invite you to make a donation in honor of this experience. That support will enable us to continue this life-saving work. And the website on this PowerPoint right here, marfan.org/donate. We will also drop that into the chat box for your convenience. And then finally, this is new that we're talking about this week, September 19th through the 26th this year is Aortic Disease Awareness Week. This worldwide event, you might have heard of Aortic Disease Awareness Day in the past, has just been September 19th, but we've expanded it out to be a week-long celebration this year. It's a worldwide event that is powered by the Marfan Foundation. We hope you'll participate in this awareness project by raising your hands in awareness of the risk factors for or aortic disease. Information is available within the app on marfan.org and in all of our social media. You'll see here examples of what folks are doing to help us raise awareness. We combine these photos to share videos of people from all around the world sharing their aortic disease experiences, and it has proven to be a wonderful awareness project, and we invite you to please take part. Thank you so much to tonight's speakers, Dr. Morris, Dr. Lacro, Alix. You are wonderful people and so generous with your time and expertise. It is such a gift to get to spend this time with you, and we are just so grateful for it. I hope you all and everyone watching has a wonderful rest of your week with the E3 Summit, and we'll see you around somewhere in another session, I'm sure. Thanks, everybody.
Thank you so much, Nikki.
Bye.
Thank you.
Bye.